Okay, so I think the recording's going. So I just wanted to say a few things before I start. So last time I talked about Dr. Babas's practice questions. So I was referring to a Word document that she uploaded that had a bunch of practice questions related to autonomics. And I don't think that she uploaded, I mean, somebody can correct me if I'm wrong, but I don't think that she uploaded those this year. So those are the ones that I was saying were much harder than the actual exam itself. She didn't? Okay, thanks. So those are the ones I was talking about were a lot harder than the exam itself. But the farming fun, that review is actually extremely on par with like the level of the exam. And just kind of like a pro tip or a hint or what have you, if you look on the slides that have like the answer explanation, like it gives you, the right answer and then the explanation for the wrong answers. A lot of times on the wrong answers, you'll see things in red, and those are typically your test questions. So a lot of times with her practice questions like that, um, you know, she'll write the question, and then there's the correct answer, but it's actually the wrong answers are the ones that she's going to be testing you over. So as you go through the questions, like make sure that not only do you understand why the right answer is right, but go through her explanation slides and make sure that you look at the wrong answers, and especially anything in red. That's generally like a huge tip off for her that that's something that is going to show up on the test. So hopefully that makes sense. Okay. So I added this session um, to make sure, well, so I could like knock out the last 4 lectures, and then we'd have plenty of time to review on Sunday evening. So actually, like once I get through this stuff, I'm actually going to pick up a U-Haul, so I'll have to run. But if you have any questions at all over the other lectures, especially the autonomic stuff, I've actually had people like study groups send me like Google Docs and stuff with questions. Um, so feel free to do that through Facebook or email or whatever. Like I don't mind that at all. Okay. All right, so thank you guys for coming. Sorry about the not the best scheduling. Okay, so let's start. Also, if you hear somebody talking in the background, my husband's working from home, so I can't really tell him to be quiet. So sorry about that. I'm not sure if you can hear it or not. Okay, um, starting with the anesthesia lecture. Okay, so the two things that I have highlighted here, talking about the MAC50 and the blood gas partition coefficient, these are two things that are definitely going to show up on the exam, probably in the form of a chart giving you a bunch of values, either with the MAC50 and asking you about the potency, or the BG partition coefficient and asking you about which anesthetic would have a faster versus a slower onset. So uh, your MAC50 is a measure of potency, and that's similar to the EC50, which you talked about in the kinetics lectures. So the MAC50 is the minimum alveolar concentration, sorry for the typo there, needed to produce anesthesia in 50% of the population. And when you have a smaller MAC50, similar to when you have a smaller EC50, that means that your anesthetic is going to be more potent. And then as far as your phases of general anesthesia, you have an induction phase, a maintenance phase, and an emergence phase. So during induction, these are not things that you need to worry about. But the gas partition coefficient, that's the ratio of concentration of anesthetic in the blood to the gaseous state. So if you have a lower blood gas partition coefficient, this means that the anesthetic is going to have a faster onset and a shorter duration. If you have a higher blood gas partition coefficient, it's a slower onset and a longer duration. So in order for an inhaled anesthetic to work in the brain, it has to be in a gaseous state in the brain. So the more soluble it is, so the blood gas partition coefficient is a measure of solubility. The more soluble an inhaled anesthetic is in the blood, the longer it's going to take to saturate the blood, and the longer it will take to have an effect as a gas in the brain. So if whatever the question is on the exam, if you know the two highlighted relationships here, you will, absolutely be able to get it correct. Okay, so malignant hypothermia, that is an adverse effect of both inhaled anesthetics and succinylcholine. So succinylcholine, remember, is one of your neuromuscular blockers, so your NM blockers. And what this is, it's a hereditary mutation in a ryanodine receptor, and it leads to an excess calcium release from the sarcoplasmic reticulum. So what you see would be things like tachypnea, tachycardia, rigidity, acidosis, rhabdomyolysis, and hypothermia. And one thing, I believe this is the ding ding for her. So the antidote to this, or to resolve this, you would give a drug known as dantrolene, and this is a ryanodine receptor antagonist. And thinking back to last year, I'm pretty sure the question involved knowing that this involves a problem with the ryanodine receptor. So make sure you know the mechanism of action for dantrolene. Okay. So one of these syndromes that you talked about that presents similarly to malignant hypothermia, that's your NMS syndromes, the neuroleptic malignant syndrome, which also can present with hypothermia and muscle rigidity. And the thing you're going to look for here is just the difference in history, like if she wants you to distinguish between the two. So if you have a person with, say a psychiatric illness that's presenting with hypothermia and muscle rigidity, that probably means that they've been given like a D2 antagonist, and you're thinking NMS. If you have a patient who was intubated and then they're coming out of surgery presenting with, hypothermia and muscle rigidity, then you're thinking, oh, they were probably given an inhaled anesthetic. Okay, moving on. So, with your injectable anesthetics, really the only thing that she had in red regarding these was the fact that your dexmedetomidine, that's an alpha-2 agonist. So alpha-2 agonism leads to hypotension by turning off the sympathetic effect. So really the thing here is just knowing what an alpha-2 agonist does, and then you could predict this effect. Propofol and etomidate, like she keeps saying, the uses of these drugs really isn't the focus, but one combination that you will see that's very common is succinylcholine plus etomidate. So succinylcholine, that's your paralytic, and then etomidate is the sedative. And that's a combination that that is commonly used for what they call rapid sequence intubation. So ketamine is an NMDA antagonist, and this produces very strong analgesia and also causes dissociative amnesia. So she mentioned, ketamine being used as a date rape drug because, since the person is dissociating, they can still follow your commands, but they're, not likely to remember what happened. So that's why it's commonly used in that scenario. And then fentanyl is an opioid receptor antagonist. It's extremely potent. I'm sure you guys have heard of fentanyl patches. They're often used in like cancer-related pain. So typically something that's very strong and only used in scenarios that are pretty bad, like cancer. Okay, so with your local anesthetics, so this test question, it has the potential to maybe seem complicated, but if you know this point right here, so if you have a patient with an allergy to an ester, you're going to give the patient an amide. If you have a patient with an allergy to an amide, you're going to give the patient an ester. So our esters are called our one-eyed esters because there's only one eye in the generic name, whereas amides have two eyes. So the example she used in class is that if you have a true allergy to Novocaine, you have likely to have an allergy to cocaine, so you're going to use an amide like lidocaine. So you'll notice Novocaine is one of our one-eyed esters because there's only one eye in the name, whereas lidocaine has two eyes. So if someone is allergic to Novocaine, an ester, you're going to give them something like lidocaine, an amide with two eyes. And the test question, it'll literally be that simple. So as long as you remember this, if they have an allergy to something with one eye, then in the answer choices you're going to look for something with two eyes, or vice versa. And that was definitely on the exam last year. Okay, so just a couple practice questions. So a high blood gas partition coefficient indicates that the drug prefers the blood or a gas. Right. Good job. So the blood. So the more soluble the inhaled anesthetic is, aka the higher the blood gas partition coefficient is in the blood compared to the air, the more it binds to the plasma proteins in the blood, and the higher the blood gas partition coefficient is going to be. So if you have a high blood gas partition coefficient, then the onset, is it going to be fast or slow? Right, slow. Okay, so which of the following inhalation anesthetics are the most potent? Right. So remember, when you're looking for a high potency, it's going to be a low MAC 50. Good job. Okay, how about which of the following has the fastest onset? Right, good job. So does fluorine. So when you're looking for the drug with a faster onset, you're looking for um, a low BG partition coefficient. Okay, which of the following is a neuromuscular blocker, or produces a neuromuscular blockade? Right, so correct answer here is succinylcholine. So remember that's one of your NM receptor antagonist used as a paralytic. Okay, so moving on to the anticonvulsants. All right, so in neuro, you're going to spend plenty of time going over, the different types of seizures. So, right now, as long as you just have a very basic understanding, that's more than enough. So, um, if you know what first aid has here, that's definitely enough to get you by. So, you can have two types of seizures, either partial, which are focal seizures, or generalized seizures. So, in partial seizures, they usually involve only one hemisphere, whereas generalized seizures are going to have a bilateral effect. And then partial seizures can be either simple or complex, and the only difference here is whether or not the patient is conscious. So, with a complex partial seizure, you're going to have impaired consciousness. And then the different types of generalized seizures, tonic refers to the stiffening and clonic refers to those quick repetitive jerks. So if you have a tonic clonic seizure, you're going to alternate between a stiffening, between stiffening and movement. So between stiffening and that jerky repetitive movement. And then with absence seizures, so this should be the one that's going to be on the exam. The thing that you need to know is the fact that absence seizures are much more common in children, and they occur due to an increased firing of the T-type calcium channels. And the reason that's important is because when you go to treat an absence seizure, I believe Dr. Babos mentioned that the only drug that exclusively treats absence seizures is ethosuximide. And the mechanism of action for this drug is going to be blocking these T-type calcium channels. Um, so hopefully, this one will show up on the exam for you because you definitely made a big deal about it. Okay. So our adverse effects of our AEDs or anti-epileptic drugs. So you're going to see CNS depression, including sedation, ataxia, drowsiness, motor incoordination, confusion, nystagmus, and decreased cognitive function, and then also possibly mood changes or suicidal ideation. And severe allergic reactions. But the two that you want to focus on, I have here in yellow, and I'm pretty sure that this has probably been a test question, 3 or 4 times over the past 2 years. But that's the fact that most anti-epileptic drugs are going to lead to weight gain. The only two exceptions, and this is extremely high yield, is topiramate and ethosuximide. So since ethosuximide is only used in absence seizures, which are most often in children, this isn't as important. Whereas topiramate, you can actually see weight loss, and that's kind of the higher yield point because typically, your teenagers or your adults are going to be more weight conscious. So, like a common question STEM scenario that you'll see is, a 19-year-old female patient comes into the ER with sudden onset seizures. And, why did she likely discontinue her medication? And it's usually due to weight gain. Um, so if you wanted to prescribe her an alternative, a good alternative could be something like topiramate, because it can actually be used as monotherapy for both generalized and partial seizures. So it treats a lot of things, and you don't have to worry about the adverse effect of weight gain. So it's a very popular drug, I guess is what I'm trying to say. And then also, the other thing that I would probably be likely to show up on the exam is your anti-epileptics that are enzyme inducers versus enzyme inhibitors. So carbamazepine, phenobarbital, and phenytoin are enzyme inducers, and then your enzyme inhibitor is going to be valproate. And I had somebody message me this morning, and they're like, why does it matter that phenobarbital is an enzyme inducer? And the most common thing that you'll see is, you may have a female patient who, presents with something like abdominal pain, and she's like, oh, there's no way I could be pregnant because I'm taking, my oral contraceptive pills regularly, and she feels like she's being safe. But if she happens to be taking one of these three drugs, carbamazepine, phenobarbital, or phenytoin, they act as enzyme inducers. So that means that by taking these, it could be increasing the metabolism of her oral contraceptives. So that can lead to an unintended pregnancy, which could obviously be very upsetting for a patient. And a lot of times you'll see in a question stem valproate used as a distractor in that type of scenario. So valproate is an inhibitor and is not going to, speed up the metabolism of an oral contraceptive. So don't be distracted by that. Okay. Just to go over some of these drugs. Okay, so again, the uses are not important this year. Like, don't sit and memorize, okay, lamotrigine is tonic-clonic, carbamazepine is partial. That's definitely not something that she's going to test you on. So, focus on the things in red. But one thing I do want to point out that you'll get asked about a lot next year is the fact that carbamazepine is definitely the first line when treating pain from trigeminal neuralgia. So if you ever see trigeminal neuralgia in like a board practice question, they're definitely looking for you to treat the patient with carbamazepine. It's very effective for that. Then some of your adverse effects are going to include aplastic anemia, Stevens-Johnson syndrome. This seems a bit random, but especially in Southeast Asians with this haplotype. So that's something that you would want to screen for because Stevens-Johnson syndrome, it's a skin and mucous membrane disorder, but it is very severe, and it's something that can be life-threatening if it's not caught early. Then also, carbamazepine is nephrotoxic. It can result in weight gain, of course, because it's not like one of our exceptions like topiramate or ethosuximide, diplopia, and ataxia. So one of our drug interactions is the fact that carbamazepine is an enzyme inducer, and autoinduction is also a possibility, so it can induce its own metabolism. So again, carbamazepine would be one of those drugs, for example, that you would watch out for in a patient who's on oral contraceptives and trying not to get pregnant. Lamotrigine, the only thing she had in red is the fact that you want to monitor the patient for a rash. So again, Stevens-Johnson's and TENS, which is basically like a more severe form of Stevens-Johnson's. There are skin issues, but they can be fatal. So that is something that you would definitely want to watch out for. Um, Phenytoin, also an enzyme inducer. And the big ding ding, I guess, here would be the fact that it undergoes zero order metabolism. So back when we talked about kinetics, I showed you guys a clip from first aid, and it had a mnemonic. It was P, like P is in the vegetable, to help you remember the drugs that undergo zero order metabolism. So other than phenytoin, do you remember the other two? Right, ethanol is one, and then what was the other one? Aspirin. Good job. So PEA, um, super high yield for boards, undergoes zero order metabolism. And the reason this is important is because if you have, just a small change in dose, it can lead to a disproportionate change in steady state blood levels. So if a patient comes in and the phenytoin isn't working, you don't want to just go and double that because you can dramatically increase, the effect of the phenytoin, which, of course, you can harm the patient. Okay, then again, topiramate, its adverse effect is weight loss. So this is basically your only option in adults as far as anti-epileptics go that doesn't have a potential adverse effect of a weight gain. So this is super high yield, and I would be surprised if she didn't put this on the exam. So for sure, make sure you know that. And then valproate is an enzyme inhibitor, so don't confuse that with your inducers. All right, our GABAergic, real quick. So we talked about barbs and benzos, so make sure you know the mechanism of action for both of those. But then also, again, phenobarbital is one of your enzyme inducers, so that's very important for this lecture, knowing your enzyme inducers. And then tiagabine, I would call that low yield, at least for now. But just realize that it is also GABAergic because it inhibits GABA reuptake. Okay, so drug-induced GCSE. So what does that stand for, GCSE? You guys know? So GCSE is generalized, generalized convulsive status epilepticus. So how do you provoke that? Two ways here. So either through drug discontinuation. So if someone is non-adherent to their anti-epileptic meds, and again, a common reason for this, maybe in a teenager. I mean, not to be stereotypical, but like a teenage girl who's concerned about weight gain, or it could be a teenage guy, who's concerned about weight gain, and they decide to stop taking their meds, and their parents aren't aware of that. That's a scenario, where you could see something like this in the ER. Or also, if you withdraw from a GABAergic, so like a benzo, or if you give someone flumazenil to treat a benzo overdose, you could also uh, precipitate this. So someone asked me, that seems kind of like counterintuitive, like you could have a seizure by withdrawing from benzos, and then you can also precipitate one by giving someone flumazenil that has a benzo overdose. And my understanding, at least, according to Dr. Babos, obviously I don't have any like real world experience with this, but according to her, she says that in the real world, chances are you're not going to give an adult patient flumazenil for a benzo overdose, because if that patient is benzo dependent, then you can produce, status epilepticus in that patient. And A benzo overdose is far less likely to kill you than an overdose from barbiturates, and that's, again, due to the mechanism of action. So when you give someone flumazenil, it's kind of like, you have to weigh the risk versus the reward. And she gave the example of, one case where you might actually do this is, say you have a 5-year-old child that comes in and they got into their grandparents' pill cabinet and took a bunch of benzos. Chances are in that case, it's going to be safe to give that child flumazenil because it would be very unlikely that a 5-year-old child would be benzo dependent. They probably just got into the pill cabinet. Okay, drug toxicity. So remember, bupropion has a risk of seizures, so you definitely would not give somebody bupropion either for an antidepressant effect or a weight loss effect or a smoking cessation effect. You would not prescribe that drug in someone with a history of seizure disorders. In that case, you would choose something like varenicline when you're talking about quitting smoking. Okay, so isoniazid. You also run the risk of inducing a seizure with this drug. Remember, that's one of your TB drugs that's part of RIPE therapy. So why would the patient be at risk of a seizure with isoniazid therapy? Right. So if you have a vita Right. So if you have a vitamin B6 deficiency, you can precipitate a seizure because you're decreasing the conversion of glutamate to GABA. Right. So you guys are correct. And then also, so if you do have a patient that presents with this, important to know that you're going to give a benzo to break the seizure and then phenytoin or fosphenytoin to prevent recurrence. Okay, so practice question. A 5-year-old female patient is diagnosed with absence seizures. Which of the following medications would be most appropriate to treat her with? Right, so ethosuximide, that's the one that's approved for absence seizures, and that's the only thing this drug is used for. So what is the mechanism of action for that drug? Right, good job. So that's a T-type calcium channel blocker. Hopefully on the test. Okay, so a 26-year-old female discovered she was unexpectedly pregnant. She had been taking regular oral contraceptive medication. 2 months ago, she was diagnosed with complex partial seizures and started prescribed therapy. Which of the following drugs was she most likely taking? Right, good job, guys. So carbamazepine, that's one of your enzyme inducers. So be careful with your OCPs with that drug. Okay. Moving on to the opioids. Okay, so starting with this lecture especially, so if it seems like I am leaving out a lot, I'm doing that on purpose because, I sense that a lot of people are kind of panicking. And Dr. Babos, she teaches like a million lectures second year, so you kind of learn how she operates. So if it's not something in red, if it's not something we bought it or she's like shouting about, she's not going to test you on it, and you can trust her with that. A lot of what she gives you, it's like beyond what you're going to be tested on, but it's stuff that like you need to know down the road. So it's like she wants to expose you now, so at least you've heard of it. But it doesn't mean that you really need to have a deep understanding of like everything she's presenting. So I'm trying really hard, just to keep it like a really high yield. Okay, so your opioid actions. So at the CNS level, opioids are, of course, an analgesic. They produce euphoria. Um, they inhibit the cough reflex. So if you've heard of robotripping, dextromethorphan, that's closely related to opioids. I don't know the exact, chemical makeup of that, but just be aware. And then also inhibition of the respiratory center. So if you have somebody who overdoses on opioids, one of the things that she stressed is the fact that you get respiratory depression, um, and that's deadly. Okay, then also you're going to see miosis or pinpoint pupils, and this is due to a cholinergic effect on the ocular motor nerve, leading to contraction of the sphincter pupillae. And then you can also see, sedation with the opioids. At the cardiovascular level, opioids are going to be vasodilators, so you'll see decreased preload and a decreased afterload. And then a big one that comes up a lot in practice questions is the fact that opioids, they inhibit peristalsis and reduce contraction. So one of the things that you'll see with overdose is diminished bowel sounds, and also in an opioid user, um, they cause constipation. So if someone is withdrawing from opioids, as you can imagine, you're going to see the reversed effect, and that's going to be a lot of diarrhea. So, of course, like very unpleasant for the patient in that regard. Okay, so with withdrawal symptoms, you're going to see increased pain. So this is really just the opposite of the drug effects if you think about it. So increased pain, dysphoria instead of euphoria, diarrhea instead of constipation, yawning, and that's the opposite of respiratory suppression, mydriasis instead of meiosis, and then piloerection and diaphoresis, so sweating if somebody was withdrawing from opiates. Okay. So your opioid agonists, I would just be familiar. Those include things like codeine, morphine, hydrocodone, hydromorphone, oxycodone, oxymorphone, and fentanyl. And then what I mean by, or what she means by full agonists with other actions. So opioids that have uses other than just analgesia. An example of that would be loperamide, so Imodium. So Imodium, I'm sure you guys have heard of. So that's an anti-diarrheal. So that kind of makes sense because opioids cause constipation. And then also methadone. Something that you don't necessarily need to know right now, but so methadone is a full opioid agonist, and it's going to occupy the opioid receptor sites in the brain. So users, if those sites are occupied by methadone, users, they're not going to feel like the same cravings for other opioids that they would normally. So I'm sure you've heard of methadone clinics, and I think those have they're going away, just because methadone, because it's a full agonist, people say there's a much higher like abuse potential there. Okay. So bringing back this high yield point here, so a partial agonist can outcompete a full agonist and precipitate withdrawal in a patient who is dependent on the full agonist. So remember, a partial agonist in the presence of a full agonist can act like an antagonist and precipitate withdrawal. So that's kind of where you know, understanding those kinetics lectures kind of starts to come into play. So a popular example of an opioid partial agonist would be buprenorphine, or it's also known as Subutex. And then I'm sure you've heard of Suboxone. So Suboxone is a combination of naloxone and buprenorphine. So when somebody takes Suboxone, the buprenorphine is going to bind to receptors in the brain, and it's only going to activate them slightly because, it's a partial agonist. So you get relief from the withdrawal symptoms that the patient would otherwise experience. But the naloxone is also going to block the opioid's effect, so that keeps the body from experiencing the high from the drug. So Suboxone, I think that that's kind of like the most favorable treatment right now. But kind of the downside to that is that Suboxone is not safe in pregnancy. So if you're ever, asked about treating a opioid addicted pregnant female, it's only going to be Subutex or methadone that's going to be safe. But like I said, I really don't think that that's anything that she's going to test you on right now. Okay. If you have opioid overdose, so you're going to see miosis, or those pinpoint pupils. The patient may be unconscious, because remember, opioids are a sedative. They're going to have diminished bowel sounds, which contributes to that constipation. And then the big thing to know here, or to be aware of, is the fact that an overdose can result in respiratory depression, and excuse me, that is really the biggest concern here. Okay. So she talked a little bit about how when you're treating an opioid overdose, you have three options. You can go ahead and intubate the patient because of the respiratory depression, or you can titrate an naloxone drip, or you can just do an naloxone push. And she mentioned that patients don't really like the third option, because you're reversing the overdose, and they're going to get all of those terrible withdrawal symptoms. So, option 1 or 2 would be much like friendlier to the patient, or nicer. Okay, so your opioid antagonist, high yield here is naloxone. So naloxone is a competitive antagonist used to reverse the effects of opiate overdose. And of course, because it's an antagonist, you can precipitate withdrawal symptoms in a patient who's dependent. But you do want to watch for the reemergence of respiratory depression. So that's another reason why, just doing an naloxone push really isn't the nicest thing for the patient, because, you can see like a reemergence of the thing that is, most detrimental to them. Alrighty, so which of the following is a symptom seen in opioid withdrawal? Right, good. So mydriasis. And so a helpful mnemonic maybe to help you remember this is, if you drink cola, you're going to dilate pupils. So your pupils are going to be dilated with cocaine, opiate withdrawal, LSD, or amphetamines. So The C, L, and the A are referring to intoxication, with the exception of opioids. So you do have to remember it's opiate withdrawal in this mnemonic. But, just knowing this is definitely something that's high yield for boards, because when they describe the patient presentation, it really helps you either rule in or rule out a lot of drugs just based on the fact of, do they have dilated pupils or do they have, pinpoint constricted pupils? And that really helps you narrow things down in a lot of questions. Okay, one more. So, skeletal muscle relaxants. So, I recycled this slide here from one of my earlier sessions, but there's tons of highlighted and red stuff in here, so I think that probably, I could see at least 2 or 3 test questions just coming from this slide alone because there's so much stuff here. Okay, so let's go over these again. So your NM receptor drugs, these include succinylcholine and rocuronium, and they're both antagonists. So succinylcholine is a depolarizing, non-competitive antagonist. So because of the depolarization, you're going to see sodium rush in, potassium rush out. So, your potassium is entering the blood, so you're going to see hyperkalemia. And so the first phase here that you see is depolarization. And in phase 1, which is the depolarizing phase, that's where you see the muscle fasciculations. And then once the receptors are desensitized and the muscles are no longer responsive to acetylcholine, then you move into phase 2. And this is known as the desensitization blockade phase. And this is going to be the phase that induces paralysis. So try to kind of understand that. And if you go to this link here, you can read that, kind of read what I'm saying again. And also important to know is the fact that succinylcholine is not reversible with acetylcholinesterase inhibitors, and that's because it's a non-competitive antagonist. So you can't, no matter how much you try to increase acetylcholine, everywhere acetylcholine is, you're not going to be able to outcompete the succinylcholine because it is a non-competitive antagonist. And then also, don't forget about malignant hyperthermia. So you can see malignant hyperthermia in with succinylcholine or with your inhaled anesthetics. Okay, so let's go down here to rocuronium. So rocuronium is your competitive NM antagonist. So because it's competitive, you can reverse the effects of rocuronium by using an acetylcholinesterase inhibitor. So for example, neostigmine, pyridostigmine, and physostigmine. And initially I did have ergophonium here, but number 1, that drug is no longer on the market, and number 2, she said that it would be the one of 4 that wouldn't work in this case. I think something to do with the fact that its half-life is so short. But yeah, anyway, so you can reverse the effects of rocuronium with an acetylcholinesterase inhibitor. So once you give an acetylcholinesterase inhibitor, you reverse the paralytic effects, but because you're increasing acetylcholine everywhere acetylcholine is, you're going to see salivation, lacrimation, urination, defecation, bradycardia, sweating, and hypertension. So if you want to treat those effects, you can use an antimuscarinic, but you're not going to reverse uh, the hypertension, because that's a sympathetic effect due to alpha 1 activation, not a muscarinic receptor. So blocking, a muscarinic receptor is not going to, block the fact that alpha 1's being activated. Alrighty, so yeah, a lot there. So make sure you go from top to bottom and make sure that you are like genuinely understanding everything that's going on with this slide. Okay. So really I'm trying to remember why I added this slide. Okay, so the reason I put this here is just, again, to show that, if you have someone who's been given, the paralytic rocuronium, and you want to reverse that, you give an acetylcholinesterase inhibitor. So by increasing acetylcholine everywhere acetylcholine is, you're reversing the effect of the paralytic because you increase the amount of acetylcholine at the neuromuscular junction, so that's able to outcompete the rocuronium, and the muscles can work again. They're no longer paralyzed. But in addition to that, you're going to see the salivation, lacrimation, urination, defecation, bradycardia, and sweating because, look at everywhere acetylcholine is. So you're increasing these things. And then in order to get rid of that, so you give something like atropine, a muscarinic blocker. So you can put a big X here, and you can put a big X here by giving atropine. So you no longer see the sweating, you no longer see the SLUD, but you still see the hypertension because you've increased acetylcholine here, so you're still getting alpha 1 activation. So understanding that is, extremely high yield for the exam. Okay, so I added this, just to remind you with sexamocholine, you see malignant hypothermia, and you're going to treat that with dantrolene, which is a ryanodine receptor antagonist. So make sure you remember this ryanodine receptor part and associate with that with malignant hyperthermia. All right. I did include this slide because the first time we talked about tizanidine, like she didn't make a big deal about it, but in this last lecture she did, and I think that it's just to make sure you understand the effects of an alpha-2 agonist. So tizanidine is an alpha-2 agonist. An alpha-2 agonist is going to turn off your sympathetic output, so leading to hypotension and bradycardia. So just be able to predict the effects of an alpha-2 agonist. But, I mean, really any of these, if you give beta-1 agonist, or you really have to understand that schematic, that's showing the receptors of the sympathetic and parasympathetic nervous system. Okay, sorry guys. All right, so neostigmine differs from pilocarpine because it has effects on which of the following? So think about, what's the mechanism of action of neostigmine? And what's the mechanism of action of pilocarpine? Okay, so just kind of to help you guys out, so remember, neostigmine is an acetylcholinesterase inhibitor, whereas pilocarpine is a direct muscarinic agonist. So what would acetylcholinesterase inhibitor, what would it do that a direct muscarinic agonist would not? Okay. Yeah. Yeah, good job. So the correct answer here is D. It has an effect on skeletal muscle. And this is where I'm seeing like a lot of confusion from people. So if you give someone a direct muscarinic agonist, you're doing some of the same things as an acetylcholinesterase inhibitor. You're acting here and here, but with an acetylcholinesterase inhibitor, you're increasing acetylcholine at the neuromuscular junction. So, yes, you're stealing my thunder because I think I have a practice question related to that here in just a second. But yeah, so anyways, by giving a direct muscarinic agonist, you are not working on the somatic nervous system. So just try to get that straight in your head. Acetylcholinesterase inhibitor versus muscarinic agonist. And then this chart here, this is from her lecture. So super, super high yield here. So with an acetylcholinesterase inhibitor, you're getting the muscle fasciculations because you're increasing acetylcholine at the neuromuscular junction. And then you're also seeing an increase in blood pressure due to alpha-1 activation. However, with a muscarinic agonist, you're seeing a decrease in blood pressure because with a direct muscarinic agonist, you're activating right here and you're activating right here. So you see a decrease in blood pressure because although your M3 receptors are not innervated, if you give an exogenous substance that's a muscarinic agonist, you can stimulate the M3 receptors, leading to hypotension. Okay, so this chart here is very important to know. Okay, which one of the following effects is caused by the ingestion of mushrooms that contain pilocarpine? So pilocarpine is your direct muscarinic agonist. If you give a direct muscarinic agonist, which one of these are you going to see? Yeah, great job. So you will see diarrhea. Someone explain why you will not see bronchodilation. Right, so instead of stimulating beta 2, what are you stimulating by giving a direct muscarinic agonist, though? So what will you see? Right, beta 2 activates bronchodilation, but what will you see instead if you give a direct muscarinic agonist? What's going to be activated and what are you going to see as far as the lungs go if you're giving a muscarinic agonist? Not M2, right, M3. Yeah, so you're going to see bronchoconstriction because of M3 activation. So remember, M1 in the head, M2 in the heart, and M3 everywhere else. How about hypertension? So why are you not seeing hypertension? And why are you seeing hypotension instead? Right, so with hypertension, you'd see alpha 1 activation, like in the case of an acetylcholinesterase inhibitor. And yeah, that's correct. Awesome. So M3 receptors are activated. So remember, if you give an exogenous muscarinic antagonist like pilocarpine, that's going to activate your M3 receptors in the vascular smooth muscle and lead to vasodilation and hypotension. Okay. And then this is, of course, super important to know everything in this picture here. And here are your M3s, which are not innervated, they're not activated or stimulated by anything that's released endogenously. But again, if you give something like pilocarpine, you're going to activate your M3 receptors and then you can see hypotension. So that's super important. And that's something that I've seen like a lot of confusion on. So that's why I kind of put these practice questions, covering that concept here at the end. Hopefully try to start clearing that up. Yes, that is correct. At least in this case. I mean, I don't want to say that that's true universally, but in the case of your M3 receptors, that is true. Okay. All right, so that's all I have for you guys. I'm going to run and pick up my U-Haul now. Is everyone doing okay? I hope this helped a little bit. And Sunday I'm moving to Morristown. So that's my rotation site. About neuro? Okay, I can try. Yeah, what's your question about neuro? Thank you. Does Dr. Leo tend to use the same slides as he does in lab for pictures? For pictures like on the exam? Yeah, I mean, I don't know that they're literally the exact same pictures, but they're close enough to where you're not going to be like thrown off by something you've never seen before. No, you're fine. Uh, yeah, I mean, I can't honestly remember if they're like literally the exact same picture that he uses in lab, but they're close enough where the picture is not going to throw you off. So, like, a lot of times, what he'll do is, like, on the exam question, he will tag something on the picture and then ask you like a second order question about it. So, like, not only knowing like what is that that's being tagged, but being able to like answer a second order question about it. Does that make sense? No, 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 no. I mean, if you want to, but I definitely don't think it's necessary. Like, I didn't study anything other than like what he presented, and I did fine. So, yeah. It's gonna be fine, guys. Don't. I know there's a lot of people who are stressed right now, and I've heard that things are confusing between Blackboard and or collaborating media site, but I believe that you guys are gonna do great. Okay. So let me know if you need anything this weekend, and still planning on having my review session Sunday night. Yeah, you're very welcome. You're welcome. Good luck studying this weekend. You guys only have a few more weeks. I hope you can hang in there. The summer after first year is wonderful.